Hi, hello everyone. Thank you so much for having me here. Thank you so much to the conference organizers. It's an honor to be with you, to have been invited. And I will be talking about hopefully some interesting concepts with you today. I will talk about food systems, food sovereignty, and CBPR with Native American populations. And this is the first time I've kind of organized the presentation this way, and I really like it. So hopefully it flows really nicely. Next slide. I wanted to introduce our center here at Oklahoma State University, the Center for Indigenous Health Research and Policy. And I wanted to note that we actually launched this center probably January to February 2019, right along with the very first tribally affiliated medical school in the United States, the OSU College of Medicine at Cherokee Nation. So that's just right up the road from us. And so OSU has invested a great deal in Indigenous health, and our center is part of that. The work that we do at our center focuses on research, particularly intervention research. And we try to work on structural and systems changes. So when I was coming up through College of Public Health training, we were really still kind of stuck in the area of helping communities make healthier choices, and really focusing on the individual level. And so my hope was that I could create structural long-term systems changes with the type of intervention that I do. And I really wanted to focus on using a community-based participatory research orientation. I have even shifted the way that I think about the intervention science that we do, because I've come to sort of understand that a lot of what we call interventions are really just efforts to reconnect and restore Indigenous knowledge and systems that we've had in place for generations to promote and sustain health. And so that's sort of a shift internally for me in how I think about intervention science, more as restoration, reconnection. So I'm going to talk about our approach, and I'm going to give you two case study examples. Next slide. I start with this food system conceptual model because it's one that I've been working with for quite a little while now, and I actually really love this model. And the reason that I love it so much is because it's one of the few models that I found around that time, I think this was published in 2011, that actually included health outcomes. A lot of the food system conceptual models that I had seen had really come from the agricultural field, and I felt like health focused people, public health people, often that didn't resonate with us. So I really like this Retin model. You could see it has the environmental resource inputs all the way to the health outcomes. And I provide it just to orient us with some context. So we really try to intervene at the producer level. And if we're lucky and we have good partnership, and the CBPR intervention study that we want to do together gives us a lot of access and a lot of truly partnership, we can do that. Oftentimes, most of us in public health are limited to what we can do. And so we oftentimes focus on, again, that sort of nutrition individual subsystem. So I'll talk about the Thrive study first. And that study was one of the first studies that we implemented that was a larger sort of long-term attempt at creating systems and policy change in tribal nations. That study focused on the consumer subsystem and a little bit on distribution. And then the next study I will share is the FRESH study, and that one has focused on the production aspect of the food system. Next slide. We also I've transitioned from, in my training, primarily using Western models of health and wellness and applying those to Indigenous communities. We sort of over the last 20 years have come to understand and realize that it's really not just cultural adaptation that we need. We actually need Indigenous models of wellness, our own models grounded in our own identity and community and concepts for health and wellness. So one of the great examples of this would be an Indigenous food sovereignty model. And Indigenous food sovereignty is defined a few different ways, but it is a model of health and well-being within Indigenous communities. And it's an orientation to our relationship with the land that emphasizes our right and our responsibility to healthy and culturally appropriate food produced through traditional practices. So it really supports us in taking greater control over our food systems by increasing traditional and healthy food access and reducing dependence on those outside packaged, high fat, high calorie foods. And you'll see it's really similar to larger scale public health efforts that intervene at the policy, systems, and environmental levels. Next slide. And finally, a term that most people use, it's very mainstream now, which is CBPR, Community-Based Participatory Research. We have always only done CBPR. It's really the sort of just kind of baseline of us engaging in a partnership. And we attempt to equitably involve all members of a community in all aspects of the research process. So we, even from the beginning, designing the research study, collecting the data, determining what data we are going to collect. Before that, collecting the data, analyzing the results, publishing. That's an area in CBPR where often community members get left behind. We co-publish with community partners to make sure that the story and the narrative that we're sharing is one from the voices of those, most impacted by the particular study that we've worked on. And we really have our accountability to the community members. We are beholden to the particular communities we partner with to create benefits for that community. That's why we're there. And so we're always striving to say, is this intervention, is this, study adding value to the community? And if it's not, then it's not a worthwhile study for us to do. As participatory researchers, knowledge for the sake of knowledge is not really what we're in the business to do. Next slide. So the first case study is the Thrive study, and Thrive was conducted with the Choctaw and Chickasaw nations here in Oklahoma. And I'm a citizen of the Choctaw Nation, so this was a real labor of love for me. It was one of my first large studies, and it was done with my own Native community. So we intervened at the convenience stores in both of these tribal nations. And if you look at the map in Oklahoma, you can see at the top far right all those little red dots. So Choctaw and Chickasaw nations make up about 25% of the state of Oklahoma, and we live in the southeast corner of the state is where our land is. So all those little red dots are where we own convenience stores. Choctaw calls them travel plazas, and Chickasaw refers to them as travel stops. But this is one of the key aspects of our economic development as sovereign nations, as we built these convenience stores, and a lot of them originally were located on sides of highways, but some of them are in smaller towns, kind of a little bit more remote, and not, necessarily right off the highway setting. And so, next slide. The way that we became involved in this study, I always say, the invitation that we got from this community, these communities, to develop this work came from a partnership interest in looking at the issue of food insecurity and its relationship with chronic disease in Choctaw and Chickasaw nations. Food insecurity is one of the things that I've studied from the very beginning of my career, because as a child, I grew up in a food insecure household, and it was very, to me, it was just something really close and personal to my own experience. And it's so prevalent in Indian country that, it was definitely like one of those key things that I really wanted to work on when I became a researcher. And it's still a problem today. And in these communities, it was and is, astonishing. 58% of natives that we surveyed in the Choctaw and Chickasaw nations in 2017 were food insecure. And we found that obesity, diabetes, and hypertension were actually higher in those who were food insecure, even after we adjusted for age and gender and education, income, and study site. So these were very high numbers. And what we also found as part of that study, you can read it, it's published in AJPH, is that more than 60% of the natives that we surveyed reported shopping at these convenience stores for food at least 3 or more times per week. So whether or not it was originally intended for the citizens of our native nations to shop at these stores like they were grocery stores, it was happening. And so we decided at that point that we would launch an intervention study that focused on the stores. And you can go to the next slide. So these are the design, and these are the design and methods that we used: participatory research orientation, cluster control trial. We had 8 stores, 4 intervention and 4 control. This was a longitudinal cohort study, and we surveyed native shoppers, just a little over 1,600 before and after the intervention. The intervention focused on the 3 Ps. The 4 Ps. I don't know why I said 3. Product, placement, promotion, and pricing. And so we implemented the intervention in Nation A. When we give specific data, we always just refer to the tribes by their preference generically. So Nation A and Nation B, the first nation, we implemented the intervention for the course of 9 months. And in Nation B, we implemented it for 12 months. And we were looking at the following outcomes. At the store level, we wanted to see if there was an increase in fruit and vegetable availability, measured by store inventory and sales, nutrition environment measure scores. And at the individual level, we looked for increased fruit and vegetable purchasing and intake. So we looked at eating behaviors, self-efficacy, perceived nutrition environment, sociodemographics, and obviously our dosage was exposure to the intervention. So we hypothesized that the more frequently someone shopped at the store, the more likely their behavior would be to change. Next slide. So we implemented this study in two major phases. The first phase was to assess the existing foods in the stores. And we needed to know, is there anything in these stores, which are typically, they're gas stations. So most of it is packaged foods. Is there anything in these stores that would meet, our criteria for healthy foods? And we had to determine that collectively with the tribes. So our criteria for healthy food was less than 30% fat and 300 calories for snacks. Meals had 500 calories or less and were low in sodium. And it was very simple. And we came up with this, criteria. And then we were given access to all the foods in the stores, as well as all the foods that the store managers could potentially order through their vendors. And through that process, we came up with a list of 5 snacks and 3 meal options that we prioritized for our intervention. And so that really was our focus on product. And this is actually, I set this slide up, I combined 2 slides. So the before pictures are the 2 pictures. The one picture really on the left, and it's the fried, they call it a hot box. And basically it's where you have the fried foods in kind of that case, and that's very, very popular. The other pieces that you see, the pictures, are actually after the intervention was implemented. And so the far left, you'll see that we implemented physical large walk-around coolers in the beginning or the front of all the stores. And so that's a picture of one of our staff, setting up the coolers and counting, the availability of the intervention foods. So that was in one nation. In another nation, we actually had to change the stores around quite significantly because there was not any food that they had access to that could meet those criteria. And so in this nation, they invested in expanding the food prep spaces in their stores, and they packaged their own meals that could meet those criteria for healthier options that we set forward. And these are some examples of those foods that they developed as part of this intervention. Next slide. This is again, sort of second phase of the intervention. What are the strategies that we are going to use to promote these new foods? How are we going to place them? And what will their pricing be? So these were sort of shelf diagrams, and we got to co-plan with the managers where things should be. The bottom picture is a before and after of some of the layout of the stores. So you can see the removals of the hot box at the entrance and putting those behind the cashiers, the replacement of the hot boxes with large walk-around coolers. We filled the end caps with the healthier choices, and the refrigeration units also had healthier choices. And then around the cashier desk, there was healthier choices. The intervention foods were placed. Next slide. These are some of the promotion materials we used. We translated some of the language into native language, and you can see here, better choice. Achukma Ashali means healthier food has arrived in the Choctaw language for that. And next slide. These are some of the pricing options. We actually established a baseline market retail value we used for the first month of the intervention so that we could see if the foods would sell, and if they didn't sell at their suggested retail price, we had an agreement with the convenience stores that we would augment any loss. And we actually did not have to reimburse them for any loss because the foods did indeed sell. They sold out, and not only that, they sold out at the suggested retail price. So neither tribal nation had to implement any pricing discounts. In fact, the only real sort of pricing deal we did were these two that you see here, and it's sort of if you bundle it, you get a little bit of a discount, 2 for $1, or add a piece of fruit and a bottle of water for, I can't really read that, but I think it's like $1 or something. Sorry, my glasses on. But that is really the only thing that we implemented pricing wise. Next slide. So our findings are published again in American Journal of Public Health, and you can read our findings. We found that the intervention did increase healthy food options, and we used a perceived and objective nutrition environment measures score. We modified the NIMS for those environments, and we have a paper on that as well that you can find. First author is Mariana Weatherall. We found that the intervention did increase purchases of healthy foods. So we had access to all of the sales data, and the sales actually went up, and self-reported individuals purchased more healthy food options, but sales overall increased. And there was a self-report increase of healthy food intake. But like other studies that only targeted the environment, we did not see any significant changes in overall dietary intake. But we did change purchasing decisions, especially among those shopping more often. And this resulted in some really exciting policy changes because the distribution providers for both nations expanded their suppliers and options. When we presented them with this list of healthy food criteria that we wanted to see in the stores, and they couldn't fully meet those criteria and provide us the foods that we wanted, they ended up sourcing from new vendors, and those vendors became permanent, and they are now available to the tribes in all of their food purchasing. The next step has been to expand the intervention strategy. So the interventions in one of the nations were implemented as permanent policy. And we also, as much as we would like to implement just environmental interventions alone, we do need behavioral change intervention strategies. And we also wanted to introduce a lot more traditional foods into this particular study. But one of the things that we found as we were doing this was and you'll hear more about this, I'm sure, in the second presentation and panel discussion after me. So the process for harvesting and preparing traditional foods is so relational that when you separate that process and the process of preparing the foods and eating the foods with your family, and you sort of distill it to a packaged, whatever the food would be, it takes away from the traditional food and the relationship that exists as part of that traditional food. So we didn't find a way to actually do that. And that's something we think a lot about, and how are we going to do that, and is it possible? So those are things that we are thinking about, as well as increasing local food options. Our primary goal was to see if we could get healthier food to really low income, very rural tribal nations. And we determined that we could, but how can we create environments where less food is shipped in and more local food is produced? And that has been something that we've been working on as well. So if you go to our next slide, I'll give you a quick overview of this case study. And this case study, for somebody that identifies as a participatory researcher like myself, is really what I consider sort of a dream CBPR study. Because again, our tribal partner came to us and they had a vision to create a sustainable food system and support Indigenous food sovereignty in their nation. And they wanted to design, by they, I mean the Osage Nation Chief Standing Bearer and Assistant Chief Raymond Redcorn. They wanted to design a farm, that develop a farm. They repurposed that land in the picture. And they imagined, they assumed that if they were to build up, develop a farm and grow local food, that it would have a positive health impact on their citizens. But they're not scientific researchers in health. And so they wanted us to design a research study parallel to this tribal initiative to create a sustainable food system. And we collectively designed the FRESH study. So that is the focus of this work. And so if you go to, if you see the second bullet there, we worked with them to develop a culturally relevant, multi-level, multi-component, this is definitely grant language, farm to school intervention, and evaluate its efficacy in increasing vegetable and fruit intake and reducing food insecurity, BMI, and blood pressure in the adults only among the Osage families. Why did we do a farm to school intervention? The main reason why is because we didn't know much about production. And so we could develop only enough to support the schools. And so that was really our first start at, how are we going, which program are we going to target as one of the first programs to introduce healthy local foods. And so we chose the Head Start Kids as our primary intervention group to begin with. Next slide. And these are the levels. So obviously at the environmental level, we were walking into a research partnership where the community was investing a huge amount in the development of a farm and environmental change. At the school and community level, we developed culturally relevant curriculum that was implemented weekly. It was 90 minutes a week, and it was for kids aged 3 to 5 that focused on touch, taste, smell. And we also changed staff feeding practices. We implemented menu changes. And these were kind of the school and community level intervention components. And then we did a passive intervention for the family. Weekly meal kits were sent home with the child to prepare with their families. We had a web-based parent curriculum with little 2-minute videos that encouraged healthy eating behaviors among the kids. So it wasn't targeting the adults. It was targeting, how do you work with picky eaters, that sort of thing. And then we had monthly family nights. And so these are the sort of general components of the intervention. Next slide. This is the design of the intervention. So 9 early childhood education centers, or ECEs, and 4 communities were randomized. The inclusion criteria: you had to be American Indian with a child enrolled in one of the ECEs, age 3 to 5, no plans within moving for the next year. The intervention went from January 2018 through December 2018. So this is about a 4-month intervention. Well, the different 2 communities randomized to the intervention group in the spring, and then 2 communities randomized in the fall. And the total participants, 369. So we had 176 parent caregivers and 193 children. And I want to say at this point that we enrolled about 94% of eligible families. So it's really, really, really high, but we were still underpowered. We didn't have enough participants. Was one of the schools had closed. And so this was the reason we were underpowered. Our primary outcomes, as I said, increased fruit and vegetable willingness to try and intake in children. And secondary outcomes: reduced food insecurity, BMI and blood pressure in the adults, and increased vegetable and fruit intake in the adults as well. Community outcomes: launch the farm and feed the Osage children. And that was a big question for us. Can we actually really do this? Can we successfully launch a farm and produce enough food to implement this intervention? And we were sort of building the bridge as we were walking on it. Next slide. So I'll go through just a few slides of our findings and then hopefully have some time for some discussion. Next slide. Oh, I should say what you saw in the previous slide was just a really nice before and after picture. We built elevated gardens for all of the Head Starts, the ECEs, to augment the curriculum. So in addition to the menu changes, in addition to the curriculum, they could go out to the garden and they could touch, taste, smell, and really feel the different vegetables and give them that sensory experience. So each of the ECEs had a little community garden. Next slide. So these are just the caregiver demographics. And the only main thing to take away here is that there were really no significant differences between the intervention and the control groups for these demographics at baseline. Mean age 33 years, most were female, about half. The highest level of education was a high school degree or a GED. And most, over 2/3, made less than $50,000 in combined household income. Next slide. So this is total willingness to try. And I had not been, as a public health interventionist, I had not been familiar with some of how complicated it gets to measure dietary intake with little kids. So willingness to try, as you probably all well know more than I, is a way to assess changes in dietary intake and behavior among these really young children. We had trained observers rate each child's interaction with each vegetable using the Farfan-Ramirez checklist. The checklist has rating options from 0, where the child doesn't even touch the food, all the way to 4, where the child eats the food. And based on this scale, a total score was calculated by adding the observer ratings 0 to 4 for each of the 6 intervention vegetables in our curriculum, which were the 3 sisters: corn, beans, and squash. And then we had tomato, spinach, and peppers. And there was a total possible score of 24, 0 to 24 for all 6 vegetables. So as you can see, total willingness to try the scores were improved in both groups. Next slide. We also looked at child plate waste. We gave each child a numbered plate with pre-weighed servings and allowed each child to consume what they wanted to consume, and then we measured their consumption. And there was a significant improvement in total vegetable intake. Specifically, we saw an improvement in beans and squash in the intervention group compared to the total group, pre versus post measurements. Next slide. For the parents' self-report of dietary intake of vegetables and fruits, though we didn't intervene directly on their diets, we did see a trend towards higher intake of fruits and vegetables. And this is cups per day. And you can go to next slide. Finally, this is self-reported food insecurity at baseline and follow-up in the caregivers. This was very interesting. Food insecurity was reduced quite a bit. And this shows the percentage of food insecure households. So the mean food insecurity score improved and fewer caregivers reported experiencing food insecurity at follow-up in both our intervention and control groups. So it was originally in the intervention group, 35%, and it went down to about 22%. And in the control group, it was about 44%, and it went down to about 30%. So this was there was a 13% reduction in food insecurity. And there really wasn't anything else significant happening in the community. So we hypothesized it might be the farm, and actually they were producing quite a bit of food towards the end of the intervention. And so it may have really started to augment the diets of a lot of the, through food sharing, a lot of the community members. We also saw moderate and total physical activity were significantly higher among the intervention group at follow-up compared to control, and obesity and high blood pressure decreased slightly in the intervention group from baseline to follow-up, while it increased in the control group. So next slide, this is my last slide. And I just want to emphasize the sustainability pieces. We were able to use data to advocate for policy changes. We presented our findings, and Bird Creek Farm was expanded by the Osage Nation. And our next study with Osage actually takes the same approach. Hopefully we will be adequately powered to implement a community-supported agriculture program. And that grant, we just got funded, will begin sometime this summer. And we also created, as part of this work, a documentary film. It premiered the 15th of April this past year. And it talks a little bit about our process in really having community-directed interventions. So that's my last slide. I want to thank our funders. NHLBI funded the Thrive Grant, and NIMHD funded FRESH. And thank you again to the organizers and the audience.